Okay, good. Thank you. Thank you, Vladimir. It's a pleasure and privilege to be here. Very, very nice, very elegant presentations. We have gone through. Let me see if it works. And thank you, my friend Imad. It's always a pleasure to be associated in the meetings you and Vladimir organized. Some pleasant memories of the meetings you did. And that was, I think, in 2018, the Congress you did in UAE. And it's a privilege, and thank you, Vladimir and Imad, for giving me this opportunity to give my respects to the father of modern neurosurgery and neurosurgeon of the century. It's a rare privilege, and I can't thank you more. I will quote from Professor Donaghy, and this was in 1986. That's my first international meeting in US when I was a registrar in UK. I traveled to US for this meeting, CNS meeting, New Orleans, and Professor Yasser Gill was the honored guest. And those times, the residents used to have a luncheon seminar or a luncheon session with the honored guest, and we had the privilege and pleasure to share one lunch with Professor Yasser Gill. But I'll quote from the introduction in that clinical neurosurgery volume in 1986. Professor Yasser Gill's greatest contribution, according to Professor Donaghy, is to neurosurgery has been his deep and thoughtful study of the subarachnoid spaces. And that is so critical. We have seen so many presentations. And my good friend Ugur showed us, and it reminded me of Professor Yasser Gill's presentation in the 1986 Congress. I understand there were a group of American technicians who went and stayed with Professor Yasser Gill for 1 year to do 3D videos of his for his operations, and that was shown continuously during the CNS meeting in '86. And he presented this bipolar coagulation technique, and he showed one aneurysm. I think, as far as I can remember, it was an MC aneurysm. He coagulated and took out the clip, and he said that you can readjust the clip. And the guy, the American neurosurgeon who was introducing him, I can't remember his name, said, "Don't do this. This can only be done by Professor Yasser Gill." And Donaghy goes on to say the village of Lice, where Professor Yasser Gill was born, is famous for two things. It's the birthplace of Mahmoud Ghazi Yasser Gill, and two, site of a great earthquake. What was cause and what was effect, we don't know. And that was such a nice introduction to Professor Yasser Gill. So let me go on with my talk. Thank you very much for giving me these opportunities. I will talk about giant intracranial aneurysms, as we have seen in these talks which have come to now. These are difficult aneurysms, they're problematic, so why treat it? The problems are wide neck, involved branches, thrombus, atheroma, calcification, and complex anatomy, because if you don't treat it, the natural history is disastrous. Left alone, almost all of them either become disabled or die within 2 years' time. That's the natural history. And unlike what is believed commonly, that these thick-walled atheromatous aneurysms don't bleed, the risk of rupture is higher than the common garden saccular aneurysm, about 10% per year. So they need treatment. But one has to go back to the basics. Again, this is very, very well has been demonstrated, the Sylvian Fisher opening. And I can't emphasize more than saying that first Dr. Dolenz showed the very nice way how to do it. Don't miss the veins, always avoid retraction. You can put, and he quoted Professor Yasser, you can put the retractor but not retract that to support the brain. And that's such a beautiful teaching from our teachers. And one cannot emphasize the importance of this for aneurysm surgery. And this wide opening of these, and this is a very, very simple instrument. This is a 26 gauge 1 cc syringe with a needle, a very short needle. I use it for people in our developing countries. You don't need fancy instruments. You need very good microsurgery, and you need the scissors to open this. Sometimes can be easy, sometimes the very, very difficult, the Sylvian Fisher. But patients, you can pay, opens the Sylvian Fisher, as is done, this very wide opening, and you can have a wide opening and avoid the retraction of the brain. And you see all the veins preserved there. And you can sometimes, as Dr. Dolan said, you can take it off, sometimes you need to cut it. Sharp cutting, sometimes with very fine, short forceps. I use a very fine, short bipolar forceps without the cable, just to dissect it, and the microsurgeries to cut when it is tough. And you need to open up everything before we go on to the aneurysm, so that we have enough space to work there, as very eminently been described by colleagues before my presentation. The exposure is the very critical thing, and the clipping is probably the simplest of the whole thing. And of course, you can't go just clip and go away, as Dr. Tolench talked about it. You need to see that everything is all right. So very, very wide opening. This is a giant ACOM aneurysm where we had to open all these areas before we could expose the aneurysm. That's what is being shown here. So that's very critical. And of course, as Mustafa nicely talked about, the role of bypass and the need that one has to learn and train for this. We can't say that you can't do it. Now, sometimes this could be a very simple solution, and more of these aneurysms are today being taken care by the endovascular colleagues. But if this is a 70-year-old lady who presented with painful ophthalmoplegia, very good, cross flow, and it's a simple surgery of ligating the carotid ICA in the neck would serve the purpose, especially in an elderly person with good collateral flow, and that's what we did here in this patient. Now, this is an interesting patient, man in his 50s, who had come with progressive mass effect for this giant ICA proximal petrous cavernous aneurysm with heavily thrombosed, and also had an AVM. And he had presented actually with headache and third nerve palsy. And we did balloon occlusion test, which was very good collateral. So we did, though he had good collateral, so we did a low flow bypass, because we were a little worried about putting a high flow bypass because of the AVM being there. So this is what we did: a STMC anastomosis and ligated the carotid in the neck. And the patient, over a period of 3 months, his headache went away, his third nerve improved and remains asymptomatic. We haven't done anything to the unruptured abnormal vascular anomaly, which is seen there, which has probably been there for many, many years. Now, this is a guy in his 60s. All his vessels are diseased, as you can see. Dolichocephalic, right ICA, left ICA, the vertebral basilar system, everything is abnormal. He presented to us with progressive visual compromise, much more on the right side than on the left side. We really were not sure how best to manage this, because all his vessels were diseased. So we sat on this patient till he forced us to do something, because he was losing vision on the right side. So we did a high flow bypass graft, and we just ligated the carotid in the ICA in the neck, and he could have some time. He's going to have problem because all his vessels diseased, but we had bought his time, and his vision got stabilized for some time. Now, this is a case of the largest aneurysm in my practice, an 8 centimeter, the blowout ICA aneurysm from ICA from petrous right to the supraclinoid. The whole thing is diseased. And he presented to another center with acute subdural hematoma in comatose stage, had a decompressive craniectomy. The patient survived and is sent to us for definitive management of these aneurysms. He also had unruptured basilar top aneurysms. So we advised surgery bypass for this ICA aneurysm. He ran away, not uncommon in my country, till he came back after 1 year with progressive hemiparesis and intractable headache, where we did a high flow bypass graft. We had to decompress the aneurysm because the radial artery graft was not, length was not enough. So we had to open the aneurysm in the middle fossa, decompress the aneurysm, and then trapped it, and then put an ECA to M2 high flow bypass graft, and sent the patient to our endovascular colleague, which was for our colleagues said that we can take care of it. But they failed because they could not spare the PCA. Then he came back to us, and then we clipped the the basilar top aneurysm. I'll skip because of time constraint. I'll skip, but this is how it looked like after 2-stage surgery at an interval of 3 months. And this is the patient before discharge from after the second surgery after the basilar top aneurysm clipping. So we can still take care of it even if the vessel is incorporated, because you can reform, and the clipping is the basic technique one has to still remember and understand. Now, this is again another patient where endovascular treatment failed. This is a 57-year-old gentleman who presented with recurrent epistaxis, and he had a road traffic accident 1 month back. He was blind, right eye, left hemiparesis. He presented to us, and he had a traumatic ICA pseudoaneurysm which was projecting into the sphenoid sinus. Now, the patient was, I said, left hemiparesis, blind right eye, and our endovascular colleague was given the first chance because it's a pseudoaneurysm. And they did multiple studies, and they said there is one bone fragment sitting in the aneurysmal wall, and they were not very happy to put any flow diverters. And they sent back to us. And then again, this is one aneurysm again, which cannot be treated by endovascular means. And we did the simple high flow radial artery bypass graft, same treatment, ECA to M2, and trapped it. While in many of the proximal ICA aneurysm, cavernous petrous, which are producing a mass, you can just ligate carotid, internal carotid in the neck and not trap it. In a pseudoaneurysm, one has to trap as we did it, and we put a clip proximal to the ophthalmic after drilling away the interclinoid, after putting a clip in the ICA in the neck. And it's important, necessary to do that because the pseudoaneurysm can backflow and bleed again. Now, this is a giant carotid ophthalmic aneurysm, unruptured 4 centimeter aneurysm presenting with visual compromise in a lady, and who had presented to us, and we reformed again aneurysm raphe, or clipping as we call it, but we knew that it will take time to take care of the aneurysm while putting the clips. So we did a protective STMC bypass and then clipped it. And especially in these large and giant and atheromatous aneurysm, very often you have at the base, we clip a little differently than we clip the sacral aneurysm. We leave a little bit of a wall of the artery, the base of the aneurysm, so that the parent artery does not get compromised. So there is a little bit of, the aneurysmal neck is open here, but that's what we have left. We have followed it up. This is now 10 years. There is no progression. In fact, the artery has become much more smooth and there is no progression of the aneurysm. So this would be the best way to take care of this. Obviously, there has been a tremendous advance in endovascular armamentarium, but I'll come to that a little later. Now, when you are doing a prolonged temporary occlusion, one has to be aware of a problem of intra-arterial thrombosis, as it happened in this particular patient. Again, extensive thrombotic aneurysm. You can see that the ICA distal aneurysm, and we did that, repaired the aneurysm, but while doing the repair, and it was not given obviously heparin because we read about it. It's ICG. We saw that you can see that is a thrombus. There's a clot inside the ICA. So we opening up the ICA and we put a purse string suture first, and then we opened up the ICA, bled back, and the clot was sucked out, and then we get back and saw the patency of the artery. So one has to be aware of this risk of complication when you are put in a temporary clip for a little long period of time. One has to be sure that there is no intraluminal thrombus, otherwise all your efforts go in vain. So we see that in a minute. We'll open up that. There's a clot sitting there. Now we put the clip open up, that it has opened up now. And now we are going to, that is the aneurysm which has been clipped. That was a clip. And now the ICG, we see the good flow, and then we accept it and we avoid a complication which could have otherwise created problem. So that is the pre-op and post-op. You can see that with the patient, good patient. Now, this is actually one of the earliest, 2008 actually. This was a presentation which I did that time. This was a doctor who had an acute headache when he was in the gym. But otherwise, by the time he came to us, he was asymptomatic, and we again was not sure whether we should treat it or not treat it, because this was a very proximal petrous aneurysm. And we took multiple opinions from international colleagues, and everybody said that it's better to treat it. He's a young fellow. I think he was in his 30s that time, and this could go into the sphenoid sinus and rupture. So after a year of observation, we did high flow bypass. This was in 2008 with the bypass, And now this just last month, he came back for follow-up. He worked actually Switzerland, but he came for follow-up. He sends me, but this time he came physically, and we did an MR angiograph. You can see the radial artery graft after 13 years still present. This is one of the longest follow-up angiogram patency I have in my practice. Just recently came actually this month, so I thought to put it here to show that radial artery graft can have a long patency. It's a good graft, and we learn from that, our cardiac colleagues, that this is a good graft. But there are problems also. Now, this is a lady with a painful ophthalmoplasia, again, was operated maybe, I think, 15 years back by me. We put a radial artery graft from ECA to M2. That's our usual practice. She had painful ophthalmoplasia. We had a very good graft. Before the endovascular colleagues took off the ICA, that's what we used to do that time. We used to do an DSA, see the patency, and then block the ICA with the coils. And this we see that before blocking, the graft was filling preferentially, and that's a good thing to see because there's a very good graft. So we are happy with it. But third day, the patient started deteriorating. We took the patient back to angio suite. You see that the graft is blocked, and the endovascular colleagues were not keen to do anything because of the fresh bypass. We thought we'll get away with it. We did not. The patient deteriorated, and she had hemiplegia. She had a massive infarct, so we had to do a decompressive craniectomy. But at the time of craniectomy, we saw that the graft was pulsating. So probably we should have been more aggressive. So this was not actually thrombus graft. This was a spasm, and this is spasmogenic artery, most spasmogenic artery as we know. But we had already had the damage. The patient survived with hemiparesis. But we learned from that, and we did learn that the occlusion of a graft can be dangerous. And obviously, when this data is available in international literature, when there is a cavernous carotid aneurysm today or a pitous aneurysm which needs treatment, these first option they are given is endovascular, which is not wrong to my mind, but not always correct also. Because of my experience, just before the pandemic, in 1.5 years, I will show you the cases which have come to us with complications. Now, this is a ophthalmic aneurysm, proximal ICA, standard of care in many advanced countries, endovascular flow diverter. This is what was done, taken care of very well. Patients had one side visual compromise, a little bit field defect. By the time in 3 months, he had bitemporal hemianopia. And this is another patient who had an ACOM aneurysm, coil and flow diverters. He had one side this visual deficit, and he came to us. You see this edema around it, and he had bitemporal hemianopia. This is a MCA again, which was attempted endovascular. You can see the disaster. They did the coil and balloon assisted, and this is the hemorrhage, had to be decompressed, and massive infarct. This is within 1.5 years. I'm showing you all this. This is an ophthalmic aneurysm, large giant aneurysm, or a large aneurysm which was endovascular treated. This patient had 30 millimeter aneurysm, and at the time of presentation, she had only visual compromise, and at the end of the 2 or 3 months, right hemiplegia, and so on. And this is a very proximal cavernous giant aneurysm. Was 2 procedure, 2 flow diverters. She came, a lady, 63-year-old, with one side finger counting disturbance at 3 feet. After the second procedure, she was blind right eye, left eye compromised, and patient was wheelchair bound. Diverter is not without risk and not epinasia. We need to remember. And as Mustafa very rightly pointed out, I always try to clip it. Now, this is a lady who presented grade 5 subarachnoid hemorrhage, a giant MC aneurysm on right side, thrombosed component. This one had bled. The left side had unruptured MCA bifurcation aneurysm. All vessels looking 3D DSA. You can see that, but it still can be repaired, which we did. And after 6 months, we took care of the left side. So both sides have been done. Of course, he's left with a left hemiparesis, but is functional, grade 5 subarachnoid hemorrhage. Now, this is a giant ACOM aneurysm, is operated last month by me. Again, you see that there was a large, large thrombus component. You see that there is a 75% is, or 3/4 is thrombosed, and this is the circulating component. And then this is what we did. This was what the aneurysm looked like. The angiogram showed the left side, A1 is dominant, but I tried to do, if I can do it from the, always on the right side, and this is, we approached from the right side. And then again, wide opening of the Sylvian fissure. This is the Sylvian fissure, which I showed you. Opening that first video was this patient's. And this is you can see the A2 of the opposite side. This is the aneurysm there. Now this is taking off a little bit of gyrus rectus here, this wide opening of the Sylvian fissure. We have already done that. Now we are trying to, this thrombosed aneurysm in the posterior part, so we're coagulating that to reduce it, but didn't do much to the aneurysm. It was still very tight and very turgid and big. And now I'm trying to see the left A1, which was dominant. And so put a temporary clip on the left A1. And then we put a temporary clip on the right A1. And we put a tentative clip at the base of the aneurysm. It's not the final, just to occlude that flow, so that we can open it up and do a thrombectomy, because as I said, it was a heavily thrombosed aneurysm. So now we open it up. And we do like endarterectomy here, have a smooth at the end of the taking out all this. We exercise some of the redundant wall aneurysm. Now, once you have taken off the thrombus, you can see a very nice wall there. And we are trying to define the opposite side, A1, that's the opposite, the optic nerve there. So we excise the redundant wall, and then we put more clips and take out the, we put fenestrated, a combination of different clips, and then we do the ICG. Combination of fenestrated, large, mini, and so on. We're trying to preserve the left A1, which was getting incorporated to the aneurysm. Very hard. Many times we did that, but I could not spare it. We will see in a minute the ICG. When we're doing the ICG, you see that there is a flow, a compromise of the flow on the left A1. But the A2s were both very nicely feeling because of the supply from the right A1. And both A2 were very well feeling. But if you see the A1 of the left side, there is it's a sluggish flow there. So in spite of my repeated attempts, I could not preserve that. So I accepted it. I remember one Dr. Dolenz talking in one of the meetings, better is the enemy of the good, because I had very good ICG preservation of the both A2s. So I accepted it, and there was no change in the patient's status. And then we did the patient, sorry, I go back. Just wanted to show the, that's the post-op. You can see the ACA feeling from the left side, but it is of course narrowed by the, but we accepted the patient that didn't have any problem. Now this is a little unusual, again, aneurysm of the ICA, distal ICA aneurysm, again, failed endovascular treatment and PCOM and anterocoronary coming out of the aneurysm. And here we do, what we did is what's called vertical stacking. Again, very wide opening of the, I'll skip that one. And I just want to show what we did, a wide opening, interdural opening of the anteroclinoid. I just want to show the way we have put the clips to preserve both the PCOM and enterochoroidal. So multiple fenestrated vertical clips. So the blades are not parallel to the parent artery as normally we do it, but perpendicular to the parent artery. And we could manage to take care of the and then we put always a little bit of cotton, and then this is how it looked. You see the multiple fenestrated vertical stacking, we call it. So old-fashioned clipping can occlude most aneurysm, and we put cotton clip wrap is a good option. That's what we think. Now, when there is an unruptured, another aneurysm, which this was unruptured on the other side, right side, similar procedure we did. Post-op angiogram showed this aneurysm, residual aneurysm, but since the patient was unruptured, we followed it up, and you can see over a period of time, this is almost completely occluded. So probably in a unruptured aneurysm, you can observe for a period of time before going for a next procedure. And this is one of the most dramatic cases in my career. This is a child, 2.5 to 3-year-old child who was operated about 12 years back. And this was a giant basilar, heavily thrombosed, calcified aneurysm presenting with altered sensorium because of hydrocephalus. A shunt was done.
Basant.
Okay, child was asymptomatic. And we send it for endovascular. This was, I said, I think 2009 it was operated. They did a coil, 17 coil. Aneurysm was preserved. Aneurysm was taken off, but the patient deteriorated and started decerebrating. The shunt was working, so we had to go in and did what we did is extradural anterior clinectomy, intradural posterior clinectomy, dorsum drill, evacuated partially the aneurysm, and this is 5-year follow-up, and this 11-year follow-up, the patient had some ocular motility problem, but otherwise functional. So I don't think that's an option. Few months after that, we got this adult patient with similar aneurysm, heavily thrombosed, and surprisingly easy. Again, the same procedure, extradural anterior clinectomy, intradural posterior clinectomy to give a little more few millimeter of extra space. And because the neck was free of thrombus, it was not a difficult aneurysm to clip. We put 2 Yasser-Gill multi-curved large clips to take care of the neck. We didn't have to open the aneurysm in this case. And YCG, we see that after that. This is the right PCA, one branch from there, aneurysm taken care of. ICG showing right PCA and the contralateral PCA. And he had a partial third nerve, which improved over 3 months. And this is the follow-up in my clinic. I think I'm running out of time. This is again the clippings technique. This is a combined modality which was sent to us by our endovascular colleague, failed endovascular homonymous hemianopia and intractable headache in a 19-year-old boy. And we did, and it's a very short clip, again, very thick walled, unruptured aneurysm. And we're trying to preserve all the perforators coming out from the bifurcation and the anterocoroidal area. We're trying to make a neck because no clip would sit there. We are holding with the bayonet forceps and putting multiple fenestrated clips, first proximal to distal and then distal to proximal, and trying to preserve all the perforators. But by the end of it, we still had some little bit of aneurysm, which could not be completely taken care of. We accepted it because the perforators were getting compromised and sent it back to the endovascular colleague. We started with this and we would end up with this, and this was much easier for them to take care of it. So this is our final trick in their armamentarium of a hypothermic cardiac arrest. This is a 3-year-old child from Bangladesh, subarachnoid hemorrhage, altered sensorium. CT angio was not informative enough. 3D DSS showing all vessels coming out of it. We did this, the last case I did hypothermic cardiac arrest many years back. I don't do it anymore because I think there is the bypass and other things can help in many of these cases. We still don't have answer to this type of aneurysms, number of cases which we have failed all the time. This is my personal series of giant aneurysms over the period of years. And this is how the outcome in the MRS. And this is how we compare with the literature. I will skip all the side. I'll go to the last slides. And I think in my practice, skull-based approach is a very good approach for a very complex and giant aneurysm. ECIC bypass is critical. And there are many advances which can help us. But as many faculty has already emphasized, practice is the way to go forward. So to conclude, microsurgery for giant aneurysms is the preferred mode of treatment when the aneurysm has thrombus or calcification, the aneurysm has branches coming out of it, or has a mass effect. Flow diameter probably good for ICA proximal to PCOM, or when you want to endovascularly sacrifice a parent vessel. I don't have an answer to dolichocephalic posterior circulation aneurysm. So some endovascular, some no treatment, majority microsurgery, I think. So must understand the aneurysm microsurgery is going to stay, and there is no way it's going to go for oblivion. But there is a balancing act. We have to understand that some patients are better treated by endovascular treatment, and we must accept it and do that. Finally, for some of my young colleagues, maybe they who are there, dream big, because I dreamt, and this was in 2008 in WANS, the World Academy meeting with Professor Yasser Gill, and this was in 2017, meeting in the World Congress. After my plenary talk with Professor Yasser Gill commenting on my talk, that was my day made on all these years. Thank you very much.